Good morning, everyone. Welcome to the American Enterprise Institute. Today's event is unbundling and rebundling health benefits, hopefully a continuing series in how we first have to take some things apart in order to put them back together again. I'm Tom Miller. I like to bill myself as Chief Entertainment Critic for the Performing Arts of Health Policy at the American Enterprise Institute. It's been a long trip over the last year, or maybe several years, but in this year of would-be repeal, replace, rename, retreat, reload, whatever, we've traveled from Gone in 60 Seconds to It's Complicated, to Weekend at Bernie's, both Part 1 and Part 2 now apparently has a sequel, Night of the Living Dead, Dawn of the Dead, It's Alive, and more recently that top-grossing horror film, It, starring Pennywise, the terrifying clown, which raised elevation of my coulrophobia, or perhaps the insane clown posse, but I don't want to talk about members on Capitol Hill. So we've got a bit of a ceasefire, perhaps, not a full peace treaty, and it might be time to redirect some of the guns of Navarone elsewhere, and perhaps just focus a little bit on creating a climate where healthcare produces, remarkably enough, better outcomes at lower costs, is accountable for what people in healthcare do, and perhaps those who can compete on a more level playing field actually would be rewarded for doing a better job, and accordingly in the other direction. That's somewhat uncontested territory. It hasn't really been brought to the fore thus far, but that's what the idea of bundling and unbundling as a general rhetorical frame might talk about. And the idea is to actually apply some evidence for perhaps higher value healthcare and begin to capture what we know and have forgotten and begin to scale it up. And that's why we're starting off this morning with, if you will, Stanford East. Not a wholly owned subsidiary, an independent branch, with a number of very thoughtful and innovative ideas as to actually find the stuff in plain sight. It took a little bit of digging. That would be a net gain for everyone. And then in our second panel today, we'll talk a little bit more about some different ways to think about competition in healthcare, innovation that doesn't raise costs but lowers them. They can operate that way and actually improve what we're getting there. But first we'll start off with the folks from, as I call it, the Duke of the West, as you will. Leading the team is, we'll get more on that later, Arnie Milstein, who's done everything in healthcare, but he's currently a professor of medicine and director of the Clinical Excellence Research Center at Stanford, which designs and demonstrates in multi-state locations healthcare delivery innovation that can be scaled up to provide better care with less healthcare spending. And you've got the bios on that, but Arnie has done tons of things before this, whether it's Leapfrog Group, working at Mercer, Pacific Business Group on Health, MedPAC, and also some excellent work years ago at the National Academy of Sciences, used to be Institute of Medicine, which talked about a healthcare imperative, which apparently wasn't imperative yet, but might eventually be, to actually find some of the low-hanging fruit. And with Arnie today are a number of his colleagues affiliated in one form or another with Stanford. Nick Bott, who focuses on had focused on the psychology of religious and political violence, but enough about what's going on at Capitol Hill this year. Other research, particularly significant today, is involving older populations, focusing on age-related and pathological cognitive decline and prevention through identifying factors associated with successful cognitive aging trajectories and validating digital assessments of cognition in clinical population. In other words, people can do better after all said and done. We have Brian Brady, who has background including medical school training at Jefferson Medical College. At Stanford, he's pursued nephrology research and completed a healthcare design fellowship at the Clinical Excellence Research Center. He's focusing more recently on improving care delivery and reducing care costs for patients with chronic kidney disease and end-stage renal disease. And also Vicky Wu, who got her MD from Stanford, focuses on clinical research, lot of work in obstetrics and gynecology, residency at the University of California, and then at the Clinical Excellence Research Center. She's designed an innovative model to reduce healthcare spending and improve patient outcomes and satisfaction in maternity care, which is where it all begins. And she's now a chief resident at Kaiser Permanente Medical Center in Oakland. So that's our lineup, and I think you're going to hear some things that, although they're imaginative, they're also practical. And we're going to turn it over to Arnie to kick things off.
Thank you, Tom. Let me begin by just discussing, what do we do as part of this digging process to find, in relatively plain sight, examples of tangible changes in care delivery that would both reduce healthcare spending and improve outcomes that patients value. We do it at a dedicated research center that Tom mentioned at Stanford that is exclusively focused only on this. That is the discovery of new ways of delivering care that would reduce spending and improve quality. So the two, I'll call it sort of, as Tom referred to it, digging techniques by which we surface these ideas and then prepare them for demonstration and testing nationally. It consists of a number of processes, but fundamentally they boil down to two things. The first is what we call bright spots research, where essentially we get a hold of large American health insurance claims databases, and we rank patient-facing clinical teams in the United States on risk-adjusted total per capita spending. That is spending not just by the insurance company, but also by the patient in the form of their patient cost-sharing obligations. And then we simultaneously rank on best available measures of quality. We identify a subset that, relative to peers, ranks in the upper echelons on both low total health insurance fuel burn, it's a metaphor to miles per gallon in a car, and also high ranking on quality. I refer to these as bright spots in the American healthcare system. What's interesting about them is, by and large, nobody knows about them because getting to these databases and linking them to individual clinical teams has been so difficult until recently. And more importantly, the teams themselves don't even know. We contact them when we say, we've analyzed this database and you're an outstanding performer on value. And first of all, they didn't even understand that it's now possible to be ranked this way. And secondly, they had no idea that they were so substantially outperforming their peers. And then our research consists of understanding what's different about how they deliver care relative to their peers who rank in the middle of the American performance distribution. That then gives us a sense of, if we wanted to help American clinical teams migrate from the middle to the top, what are some of the tangible changes in care delivery that would have to be executed? And then the second thing we do is just the boots on the ground, and all the fellows, former fellows at our research center have done this. We're just methodically dig through this mass of relatively unprocessed information on changes in care delivery in particular domains of healthcare that have actually led to lower healthcare spending and better clinical outcomes. This just gives you just sort of a sense of, the left-hand column is simply a summary of some of the clinical areas to which we've applied this discipline. And on the right-hand side, you see what we think is the American opportunity to simultaneously improve quality, but in the column, I've essentially specifically focused on what we think is a reasonable estimate of how much total American healthcare spending, not just in these categories, but total American healthcare spending, would go down if the ideas that one pulls out of this mining operation were simply more widely, no, I shouldn't say simply, but were more widely adopted. And as you can see, primary care has disproportionate leverage because so many patients are exposed to primary care. That's one reason. And secondly, primary care is the place where the most the most opportunity to prevent escalation of diseases to the point where they need more expensive care occurs. And it's also equally important the point where a primary care doctor has a choice of referring patients to a more or less cost-effective hospital or treatment option. And then I circled three other items on the list, just because the presentations you're about to hear today refer to one opportunity within each of these three categories. So we're going to sequence this in terms of hearing from people who I describe to my faculty as the people who will succeed us. That's what these three people are. That's who these three people are. But But essentially, we'll start with Vicki, who led a 3-person year-long team that did nothing but ask the question, if we were to reformulate how American maternity care is delivered, what's the best opportunity to lower spending and improve quality? And as you can see, across this alone would reduce total American healthcare spending, we think, net of the cost of implementation by about 1 percentage point, which, multiply that times whatever you want to use as your number for American healthcare spending. But it's roughly a $30 billion opportunity to make healthcare more affordable. Then we'll move on to the middle stage of life, and Brian will discuss what his team learned when they were asked to focus on all chronic illness care that was sensitive and affectable via medication. And his team came up with, again, I say to the teams, no more than 3 ideas. The American healthcare system needs simple, practical ideas, not a gigantic, new operating system, which many struggle to implement. And I'll let Brian describe what his team found, and then we'll move to Nick and the last phase of life, dementia care. For those of you who are not aware of it, HHS has, during the Bush administration, projected what's going to be the single biggest draw on the American on the federal biggest source of growth in American healthcare spending, paid for by the federal government over the next 20 years, and not surprisingly, it's going to be for the care of people that needing long-term care, and in-home support services, and a disproportionate share of those people have dementia. As you can see, Nick's team came up with 3 ideas that they project, with some supervision by a health economist, could reasonably expected to reduce total American healthcare spending by 1.5 points. So, because to keep things simple, each one of these speakers is just going to pick and describe one of the 3 ideas that they surfaced, but I'll tell you that just these 3 ideas, these are essentially, they had to go down to 1 of 3 ideas within each domain, are worth collectively, I calculated last night, about a $75 billion reduction in healthcare spending and substantially improved patient outcomes. So what are these things? Let's begin with Dr. Wu and maternity care. What's the opportunity there, Vicki?
So my name is Victoria Wu, and I'm an OBGYN. And I spent the year working with Arnie trying to address the question of how can we improve value in maternity care and in the health delivery system. And so there are 4 million births a year, and it's one of the top reasons that women go to the hospital. It's one of the top expenditures for payers. We calculated that we spend about 87 billion in payments for maternity care every year. And we also know that costs for birth are increasing over time, but our outcomes are not better. So when we looked more closely at where these costs are coming from, the main cost is coming from the birth episode, and 60% of that is going towards the facility fee, which is the essentially hospital overhead. And we also know that our C-section rate is too high. This is a soul-searching dilemma in OBGYN right now. 1 in 3 babies are born via C-section, and there's a lot of good data that shows that best outcomes for mom and baby is a C-section rate closer to 19%. Our professional society has set 24% as our standard, and we are still well above that as a nation. So we thought to ourselves, we're trying to address these very high overhead hospital costs. We're trying to reduce the C-section rate. What is a solution that could help improve our value in maternity care? And our solution is to create outpatient hospital-affiliated birth centers. What is a birth center? So a birth center is a building where low-risk, healthy women can come deliver their baby with the help of a midwife. And our vision is that this birth center is a building that's right outside the hospital. So you're low risk and you qualify to deliver in this center. When you go into labor, the midwife is with you through your labor and then delivery, and then you go home. Should anything happen and you need to be transferred to a higher level of care, you transfer them out of the birth center across the street into this hospital where OBGYNs are there on labor and delivery and can provide higher acuity care. There are birth centers currently in the US. They serve less than 1% of births, but they are problematic how they currently are. So what are the barriers right now? One, most birth centers are independently owned by a single midwife, so they aren't necessarily integrated into a healthcare system or even have contracts with a hospital system. That means that when outcomes aren't going as well and they need to transfer, there's a delay in care for these patients, getting them into a hospital. There's sometimes distrust between the providers, and so delayed care in an emergency leads to poor outcomes. That's a problem. Also, there is a large amount of heterogeneity in terms of accreditation and licensure. So currently, birth centers are not required to be accredited. That's an optional choice. Licensure differs across every state. It actually differs by county, and at least in California, where you are also not required to be licensed. It's an option. And so many places choose not to be, and so there's no minimum standard of care for birth centers. There's also heterogeneity among the providers that work in birth centers. So there are many different kinds of midwives. There's nurse midwives who train as nurses first and then become midwives, or there are what is colloquially called lay midwives who maybe just apprentice themselves to a midwife in the community and then continue to care for patients after that. So this also leads to heterogeneity in outcomes because there isn't a minimum standard necessarily in which these midwives are also operating. However, we know that birth centers used in an integrated system can have excellent outcomes. In the UK, they have freestanding midwifery units, which is essentially a hospital-affiliated outpatient birth center. And these are part of the National Health Service. So low-risk women can deliver in these freestanding midwifery units, and should they need a higher level of care, they can be transferred quickly. And there's no communication barrier in the same way. They're already part of this healthcare system. And so these concerns about communication are no longer as large of an issue. They can seamlessly be transferred. Birth centers also cost about half that of a birth in labor and delivery. There's a lot of evidence that shows that births in birth centers have less medical intervention and a lower C-section rate. We estimate that about 70% of births in the US are low risk. So even if 40% of women decided to deliver in a birth center, you're looking at significant savings. Medicare currently pays for 50% of births in the US. So
Medicaid.
I'm sorry, Medicaid.
Remarkable.
We call it Medi-Cal in California, but that is there's a remarkable savings association here if we could direct our low-risk women to deliver in these birth centers. So why should we do it? Outcomes, there's good studies that show that outcomes are the same, if not better. There's a lower C-section rate, and there are less medical interventions. Women want this option. A lot of women are looking for a more physiologic birth experience. They're interested in one-on-one care with a midwife as opposed to being delivered by their OBGYN who meets them at time of delivery. And they only want medical intervention when it's necessary. And so there's a strong demand for this. And finally, it costs significantly less. So our low-risk women could deliver safely for less at a birth center and still have excellent outcomes.
So multiplied times all of American healthcare spending, this single element of a three-element model that Dr. Wu's team came up with, we estimate would reduce total American healthcare spending by almost 0.5 point. One idea. Let's now move. Let's move later in the life cycle to people, with chronic disease. We're primarily talking about people depending on their socioeconomic status between the ages of 40 and 70, 80 years old. Brian, what did you find?
Thanks, Arnie. Good morning, everyone. Our group focused on how could we treat people with chronic disease better through using their prescription medications in a better way so we could improve their health outcomes and, like Vicki and other teams, hopefully do it at a lower total cost of care. Our team found that there are many opportunities for patients with chronic diseases to be treated differently and accomplish these better health outcomes and lower costs of care. why do we focus on chronic disease? We know that 7 out of 10 deaths in this country are caused by people dying of chronic disease. And we also know that 86 cents of every dollar we spend in the US goes to treat patients with chronic disease. So the target was large. Chronic disease, unlike infections or other types of illness, requires many years to develop, many years for the patient to live with, and then ultimately the data shows that patients end up dying of these diseases. So there's lots of time for us to intervene on these patients to do a better job. And what we uncovered in pursuing our literature search at the beginning of our fellowship year was that there are systems out there that have reimagined how chronic disease care should be delivered. This then prompted us to go out to visit these high-value sites that Arnie mentioned and find what are people in the community doing to treat their patients with chronic disease in a better, more cost-effective way. The idea that we focused on, that I'll focus the next few minutes on, is that the health systems at the vanguard of care have decided that there's so much involved in chronic disease management that many of the time-intensive tasks required to keep patients healthy through their medication management could be downshifted or offloaded from physicians, who typically hold the power of doing everything, to clinical teams led by clinical pharmacists. So taking a step back, I think we all know what chronic diseases are. These are the diseases we hear about every day: high blood pressure, diabetes, cardiovascular disease. These are the medications which many of Americans, many of us in this room, probably take every morning. What we found that was shocking was that 50% of patients in the US take their medications as the doctor prescribed. The other 50% don't take their medications as the doctor prescribed, and this leads to downstream untoward health outcomes. So if I can't control Arnie's blood pressure well enough over 20 years, there's good data to show that his kidneys may fail, he may have a heart attack, or he may have a stroke. And so how do we get at this problem? We know that in addition to the costs associated with chronic disease, it's estimated that this non-adherence problem costs the US about $100 to $300 billion annually. So this is a major problem. What these health systems on the vanguard of care have decided is that adherence is much more complicated than we used to think. No longer can physicians write a prescription in the office, give 2 or 3 minutes of counseling, and send the patient off into the ether and expect that they're going to come back in 3 months with perfectly controlled blood pressure. There's tons of research to tell us that adherence is much more complicated than that, and often involves deeply rooted behavioral change mechanisms that really take time for us to understand why patients may not be taking their aspirin or may not be taking their cholesterol medication. So what these health systems have done is capitalized on the expertise of a clinical pharmacist. These are pharmacists who go to school and study medications and pharmacotherapies for 4 years, whereas we in medical school get about 3 to 4 weeks, I think, of pharmacotherapy. So they are very well poised once the physician has made a diagnosis and decided, I want to start my patient on X therapy. They're very well poised to then take that patient into their chronic care clinic and deal with the day-to-day, time-consuming efforts that are required to keep patients on track. Some more shocking data that we uncovered, about 50% of non-adherence is intentional. So when I write a medication for a patient, there's a 1 out of 4 chance that they will just not take it as prescribed by intent. 25% of non-adherence is cost-related. So there's a good chance that when we write for medications, they go to the pharmacy and they're not able to fill it because it either may not be covered by their insurance or they may not be able to handle the copay. And these kinds of fits and starts in the system are what cause patients to become non-adherent too often. So if they go to the pharmacy and they're denied and they try and call the physician, they're likely in a room with another patient and not able to deal with the matter immediately. Whereas systems that we visited and robust demonstrations that exist in the literature have shown that teams of clinical pharmacists are able to much more facilely deal with these daily interruptions, we'll call them, that eventually lead to non-adherence. So in our second column there in the middle, you can see that the solution we are hypothesizing will improve clinical care and reduce cost of care is by taking three important tasks of chronic disease medication management from the physician and offloading them to a team of clinical pharmacists. The first is patient support, and this is all of the discussion and education about their disease and medication that, though physicians have excellent intent and we want the best for all of our patients, we simply are limited by time, with the average primary care visit being about 15 minutes and the average patient having about 2.5 conditions. You can see where there may not be time to answer all the patient's questions. So offload patient support responsibilities. Offload clinical effectiveness responsibilities to the clinical pharmacist, and that is this medication that I prescribed 2 weeks ago working for you? We know that the studies show that it works for a well-controlled population, but is it working for the patient in front of us? And too often we know that it takes more than the first shot for a medication to work for a patient. Thirdly, we'd offload the discussions about cost effectiveness to clinical pharmacists as well. And this is that problem of cost. When they go to the pharmacy, they're not able to get it filled. Or there may be a more cost-effective option in their insurance design formulary that could save them money and maybe provide the same outcomes in the long run. So what these systems have done is taken some of these time-intensive responsibilities and downshifted them from the physician to teams of clinical pharmacists who, for too long, the literature shows and people on the front lines know, have been highly underutilized. In this way, we get all the people on the clinical team operating at the top of their license. And when you speak to physicians in groups across the country who do this, we heard fascinating stories about, I can finally practice medicine the way I went to medical school to practice medicine, where I make the diagnosis and operate at the top of my license. With the aging population and chronic disease becoming a larger burden by the year for our country, with medical knowledge expanding at the exponential rate that it has for the last 30 years, I think we really do have to re-examine and reimagine how we as a medical community care for our patients with chronic disease, because time is the limiting factor. And this opportunity, the literature shows, not only improves diabetic control, cholesterol control, blood pressure control, but it also saves patients unnecessary visits to the emergency room, and in the long run will save them end-stage disease such as kidney or heart or stroke disease. And we estimate that total cost of care in a very, very conservative estimates could be reduced by about 2.6% with this model.
Thanks, Brian. All right, let's now move to late life and dementia care. What's the single best opportunity to lower American healthcare spending and improve quality, Nick?
Sure. So our team was tasked with asking that question, and it's a large and growing problem in our country. It's a $230 billion price tag right now for the total cost of care of persons with dementia, and in 2030 we're projected to have about a full 20% of our population over the age of 65. And so the costs are continuing to grow with this problem. And we also know within that $230 billion, 40% of the per person annual payments are going to long-term care services, and a full quarter are going to acute hospitalizations. And as our team delved into the literature and started asking questions about where are these unique opportunities to provide high-quality care at lower cost, we found a really unique intersection between the reality that individuals with cognitive impairment and dementia are more likely to have hospitalizations due to additional medical comorbidities relative to their non-dementia counterparts, but also how that interacted with the long-term care that they would end up requiring. And the kind of the glue that we found between those two components was an unfortunate reality that acute hospitalization in the cognitively impaired and dementia population is dangerous. So the kind of diamond that I want to speak to right now is the difficulty of preventing and managing delirium risk in this population. So for those of you who aren't familiar, delirium is a form of acute brain failure. It's characterized by confusion. It can be include psychosis, disorientation. And for individuals with cognitive impairment and dementia, this is incredibly problematic. In fact, in both prospective longitudinal studies and in post-mortem pathology studies, we actually find that delirium superimposed on dementia actually increases the speed at which individuals with cognitive impairment and dementia decline, both cognitively and functionally. So you can imagine if dementia is a form of chronic organ failure, in this case the brain, that already is causing a slow but sure decline in cognition and function. Delirium literally just presses down the accelerator. Unfortunately, because of the medical comorbidities that this patient group has, there's a high likelihood of these individuals ending up in the hospital. So essentially, when you run the numbers, about 1 in 3 individuals with cognitive impairment or dementia is likely to end up contracting hospital-acquired delirium due to a hospitalization. And this is a form of what we call friendly fire, where the medical care that you are delivering that may be necessary and really important to address whatever that medical need is can have the untoward effect in this population in particular of actually hastening their demise. And we know that this actually also balloons the costs associated with this population in terms of longer and more complicated hospitalizations, and then also hastening long-term care placement. So the good news is that we actually have really great evidence and protocols for multi-component, non-pharmacologic prevention and management of delirium. And what's really exciting is that these programs and protocols are not expensive to implement, but unfortunately they simply aren't represented in our current care of older adults, and certainly not a standard of care for older adults experiencing cognitive impairment and dementia. So just to give you a brief understanding of what that looks like, the Hospital Elder Life Program is probably the most well-known multi-domain non-pharmacologic program to prevent and manage delirium. And it might sound surprising, but this program essentially consists of adequate hydration, early mobilization, reorientation to time and place, cognitive stimulation when needed, as well as ensuring that adequate hearing and vision optimization through aids, if necessary, are part of the standard care of an older adult who's being hospitalized. And the results of interventions that include this multi-domain or multi-component intervention are pretty startling. So you see a 50% risk reduction in delirium prevalence, and you see dramatic reductions in the severity and duration of delirium when it is contracted. And when you apply this to a patient population who has a speeded cognitive decline when they contract delirium, you can see how the cost savings begin to add up very quickly. If you prevent delirium or even prevent the duration of that episode, you are literally saving cognition and function, which is saving dollars, as these individuals can stay at home longer, they can get out of the hospital sooner, and they're less likely to be readmitted for additional complications. So when our team looked at this, we said, this is unbelievable. Why can't this become a standard of care in our country? And this is simply for hospitalizations that are acute and necessary. There are additional components in what we call cognitively protective acute care that include redirecting individuals who are cognitively impaired to alternate means to receive their hospitalization. So hospital at home is an example of this, as well as what's becoming described as prehabilitation for elective surgeries. But just implementing help-like protocols to prevent and manage delirium would have a net U.S. savings of 0.55%, just that alone.
Okay, thanks, team. Just gives you a sense of these, what I refer to as sort of diamonds on the desert floor that you can pick up in less than a year if you begin to methodically dig through the evidence. And these are things that are right now are isolated bright spots in the American healthcare system. that would not be complicated for other health systems in the U.S. to adopt. For that to happen, I think we would need to think about, and I'll move into our policy discussion now, some changes in American health policy, and I'll just walk through a few and then show you a little evidence that backs up some of the assertions that I'm making. First of all, if you looked at that list, you begin to see that even if you cut those savings estimates that I showed you for the first 10 categories of clinical care that we've examined, it's near term. They represent capturable efficiencies that I think would, on a net basis, knock down American healthcare spending by about 15% and improve healthcare outcomes. And that aligns with the National Academy of Medicine report about 5 or 6 years ago that estimated about a 15 to 20% opportunity to lower American healthcare spending through efficiencies not only in healthcare but also health insurance administration. There were a number of us on that planning committee who believed that in that estimate we may have leaned a little bit too heavily on adjusting it downward for political realism. I think most of us on the committee felt that the number was probably double that. And one of my colleagues in Utah, Brent James, believes that the real estimate of capturable savings while improving quality is north of 50%. But we know it's somewhere in that range of 15 to 50. And if we even hit the low end of that range, a lot of the political conflict that over whether we do or do not subsidize health insurance, and if so, for which people, could then be taken off, and we could then politically fight over other things, which I think would be a welcome relief. And the other thing I would comment is, because it reflects on one of the recommendations I'm going to make, and you heard this theme in some of these presentations from these three clinicians, is that a fair amount of the opportunities would require a little bit more state flexibility in terms of scope of practice and health professional licensing. And that's been a very tough area politically in some, for most states. Some states have been quite progressive, and I think that's the beauty of a 50-state federal system, is that we can cite some states that have shown a little bit more flexibility in professional scope of practice, and those are often the places where these models are working best. Second point is that right now we're in a country in which clinicians and clinical-facing teams really don't have a clue as to how they're doing across all payers on total cost of care and quality. So nobody knows whether they're, to use a baseball metaphor, whether they're hitting 350 or 150. It's a crazy situation that I think in 50 years we'll ask ourselves, what were we thinking? And we also don't really know across all payers how we're doing on quality. And the last point I would make is that this is not an industry that previously has been subjected to a lot of pressure for value, for cost effectiveness, for clinical outcomes, just because the information has not been there. And so I do think there is some evidence, which I'll cite very briefly, that backing up stronger incentives, be it how the federal government and the states pay, or be it through how the private market, what the private market demands, that having a little bit of period where we have something analogous to a farm agent would help, because these are not, American healthcare systems are not that good yet, and I know that other speakers who will follow later will comment on this, at changing systematically on a continuous basis how they deliver care, how they deliver their services to make them better and more affordable. What are the policy levers specifically that I thought I could provoke some discussion with? The first is to extend the great progress we've made, beginning with the second Bush administration right through the Obama administration, but to extend publicly reported, I guess publicly was spelled it wrong, sorry about that, publicly reported value rankings by payer type, both for individual hospital service lines, not hospitals overall. We've made some progress there thanks to CMS, but actually now, okay, well, I'm not going to the hospital for anything. I have a particular service. I'm going in for cardiac surgery. I'm going in for a transplant. We need information at the service line level, and then specific ambulatory care teams. I like the idea of having a big a rating for 1,500 doctors. I now have that for some groups in California. But at the end of the day, I'm going to go in and be taken care of by a particular clinical team, and I want that clinical team to have a clue as to how they're doing on making good use of my money and taking care of my health. And we have the beginnings of this. We are beginning to support these all-payer claims databases, and in a lot of states, both red and blue, these have gotten going. But this is an area that we're not spending much money. It wouldn't take much more to universalize this. Secondly, I do think we can incentivize states to align non-federal payers in their states with the kind of MACRA-based value sensitivity that we're now committed to. As you know, MACRA is committed to plus or minus 9% for doctors based on, in essence, a measure of value, quality and efficient resource use by 2022. But by and large, the private payers are not in the game. And states, because they regulate health insurance companies in their state, and because they also buy a lot of care for their state employees and Medicaid patients, they are in a position to create some alignment with the MACRA measures. And yes, they may use different means than payment adjustments because, as you know, unlike Medicare, private payers can't tell hospitals and doctors how they're going to be paid. But what they can do that private payers can't do yet is to begin to use value-based insurance designed to encourage their populations to gravitate toward clinical teams and health systems that are getting better clinical outcomes and burning a whole lot less health insurance fuel in the process of doing that. And then last but not least, as I mentioned, incentivize states to begin to flex health professional licensing via small demos. I don't think that we're ready in America for a mass transition because there are some downside risks to doing this. I'm doing it cautiously and subjecting it, as you'll see, based on some of the criteria I suggested. We keep it small and we make sure it's done with reasonable scientific rigor. We do have a clinicaltrials.gov website, which would be a logical place where you could put this if you wanted really good quality evidence that as to whether this was indeed generating clinical benefit and lowering cost. So let me make a case for why these three ideas make sense, and just use, from the early Bush administration right through Obama, we have experimented with a lot of different ideas as to how you might improve quality and lower cost in America. And so there's an opportunity now to look back and sort of say, what are the bright spots in terms of approaches that have gotten much faster improvement in quality and lowering the cost of care? And my favorite is the comprehensive primary care Medicare demo in Oklahoma. Now, the fourth-year results are about to be released. They're even better than the first three results. But let me just share with you some of the already publicly released two-year results, but tell you that this was not just throw ideas out there and let the doctors figure it out. This illustrated almost every point that I just made in terms of policy recommendations. First of all, multi-payer alignment in a state. They were able to round up the payers, Blue Cross, the major Medicare Medicare Advantage plan in the state. So you got two big, let's call them private insurers, and then also get Medicaid and some self-insured employers in the game. So at the end of the day, they were coming to these doctor practices and saying, the rewards that you're going to flow if you can improve quality and lower healthcare spending are going to apply to almost 90% of the patients in your practice. So that's multi-payer alignment to the max. Beautifully done in Oklahoma. And it sort of did not bully doctors. It was a multi-stakeholder governance, so the doctors had a chance to say how this should work. It wasn't just unilaterally imposed. Hospitals were represented. It was not a monopsony or oligopsony play. The other thing they did is they realized that they needed a farm bureau, and so they invested in support of these doctor practices to make these fundamental changes. The other thing they did is they got the doctors tied in and the big health insurers into a health information exchange. So doctors actually knew what was going on with their patients, had a clue as to what their total cost of care and quality was, and were not in the dark if some of their patients were not liking what they were getting from Dr. A and were also getting the same medication or conflicting medication from Dr. B. And then there were some other, anyway, just that's the layering that really, I think, accounted for this, and that's what Dave Kendrick and Dan Duffy, they said this was the magic. It was this multi-level layering that made it happen. So let's just look, year one, and you can go on the website, CMS website, and see what the results were subsequently. But they were the only state that really turned all of these dials, in a very successful way, got such a big share of the payer market to kind of align with the CMS measurement and incentives. And you can just intuit, the bottom line here is we're, in all of their CPC states where the same ideas went out, but that we weren't without this simultaneous multi-layered support, the expenditures went down by 2%. That's actually pretty good in year one if you think about some of the ACO results. But in Oklahoma in year one they got 7%. And you can just intuit why this might work. I mean, you go to a doctor and say 90% of your revenue is now going to flex based on your ability to take these ideas and lower cost and improve quality. Now let's, I want to go to the second example and then I'll wrap up. And that's the thing I love about this example is this is the results for years 1 and 2 in Medicare Advantage. Now presumably, Medicare Advantage, there was a Medicare Advantage plan out there doing everything under the sun to get the providers and use their own case managers to try to lower the cost of great care. They had every incentive to do so. And so enter stage right, Oklahoma CPC. They go to these doctors and they say, look, here's 4 or 5 fundamental changes in how you deliver care we think will improve value, and we're going to help you get there, and you're going to be rewarded by multiple payers if you get there. What were they able to do on a Medicare Advantage baseline? Could they beat the 7%? And now they have, remember, 2 years relative to the CMS benchmark to do it. And I guess there's something wrong with the formatting, but anyway, over 2 years they were able to lower, for the Medicare Advantage plan in Oklahoma, per capita spending by almost 14%, which is a huge on a Medicare Advantage baseline, and simultaneously drive all the quality scores northward. So I think that's what I'll call sort of illustrative evidence for the policy changes that I recommended. And a few closing observations is, at this point I think we're not just related to the work we've done, but the work that a lot of others have done. I think we have a starter set of specific delivery system changes that would substantially improve affordability and quality of American health care. We have much greater clarity on some of the supplemental changes that are required to accelerate adoption by American clinicians. And the only question now is, will we get the job done? Tom?
That is always the question, but we've proven it works in practice. Now we'll work on it in theory, I suppose, so that people can claim credit for it. I found a common element in the 3 presentations. Defects after a poor birth experience, not taking your meds, then cognitive decline and delirium. Sounds like standard congressional legislative process to me. But that is the big question. I mean, you gave folks in Washington a little bit of a taste. They go, all right, that's what you might be able to do in clinical practice. Now, how do we apply this in policy? Because we get to put some bows and ribbons around it and make it look like we made it happen. And you've seen the literature for a long time. There's the long-standing lag. Things that we know in the literature, in scientific practice, you yell it out the window, you do your various mechanisms, and then, 15, 16, 17 years, it begins to show some. And that's just among physicians, let alone policymakers. So you work a lot at how you can first make this real, but then execute it again and again and scale it up. Some of that's policy, but what's the larger lesson in terms of how we move this from the drawing board, all this excellent work, so that it becomes more prevalent?
Yeah, I do think, at a minimum, multi-payer, kind of alignment. Doesn't have to be perfect orchestration, but right now there is not anything, these clinical teams are being subjected to different definitions of value, and in many cases, particularly in the private side, these clinical teams aren't seeing any variation in their income or their public recognition associated with higher value. So that would be,
And that does get down to the payment side, which is you're prying loose some money in the food chain,
right,
and reassembling it. That's usually where the battle comes down.
Yes.
How do you break through that? Because it does mean that some things are going to be disrupted.
Well, I think what my colleagues in Oklahoma would say was the key was sort of multi-stakeholder alignment. So they didn't, these weren't 2 reformers who were out there alone. They actually got support from the, from the physician community in Oklahoma. They got support from the payers. They got support from a subset, not all the hospitals. I think hospitals realized that these more efficient approaches, can be somewhat problematic in terms of the hospital bond ratings. But they got multi-stakeholder support. And last, I think most importantly, is they realized that our health industry is not at a state now where it isn't like the chip industry where you just say, oh, that's a better idea, we'll get this universalized within 6 months, or we'll go out of business. That's not been the history of this industry. And so they realized you do need a farm bureau. And so Dan Duffy and Dave Kendrick put that together. And so it wasn't simply, here's the idea, here's the incentives, best of luck. It was, at least for a transition period, which is what happened in the American agricultural industry. We're gonna give you some farm agents who can put you in touch with a fellow farmer, who actually made the transition successfully, and they'll share with you some tips that that somebody just like you found to be critical in getting to the top of the rankings and winning a substantial bonus.
We've got all those unemployed agricultural extension service people and say, I've lost my farmer, maybe I can help out some doctors. We're going to go to the audience for your questions and disguised editorial comments in just a minute. I wanted to ask the young physicians, we'll get a little different perspective. You get all charged up, you learn all this stuff, you find the evidence, and then you look at the healthcare system and you go, whoa, it's not reacting that way. Any of you, just give me an experience between that disconnect between what you learn and you want to do well and you want more people to do this, and then working within a system which is, if not brittle, a little resistant to rapid change. Any of you?
I mean, I'd say at least within the dementia space, there's a lot of work that can be done in challenging the purely kind of cure-based paradigm to including care as part of the overall strategy. I didn't say this when I spoke, but if we really consider delirium as an accelerant to cognitive and functional decline, and we have a way to stop it, it may be the closest thing we have to a disease-modifying agent until we find a drug that works. And I'm 100% in agreement and hope that we find a disease-modifying agent. But I think that sometimes our quest and our desire for a cure can obscure or kind of overshadow the need for, and really the importance that needs to be given on the advocacy side, whether it's from patients or patient groups, of high quality care. And in this case, high quality care for individuals with cognitive impairment may actually be some of the most important work we can be doing in terms of sustaining their lives and keeping their quality of life high. So I think that's at least something that I have kind of taken away as our team looked at this problem as an important, I think, tension that we need to kind of push.
I think maybe two things. One, when you're practicing in an environment where there are already many things that people want to add to the medical school curriculum, this is not an area that we are trained to be comfortable in speaking to our patients about, speaking to our colleagues about. Being cognizant of the cost of the treatments we prescribe is traditionally, not something that we, as providers, are excellent at. Let's put it that way. And then also in working within a system that is predominantly fee-for-service, meaning the more that I do, the more I can bill. Those often put us at odds with thinking about particularly cost as part of the value equation. And so I think, what a lot of us are getting at is there's so much investment in new mechanisms of, like Nick was describing, new mechanisms for therapy. I think that the bit of work that we've described here gets at, now I think it's time to invest in how we use the therapy, how we get it to people, how we get my last count was 27 antihypertensive medications actually into patient systems so that they don't die of a heart attack. I mean, these are the more global questions that I think we at the center are looking at. But you're absolutely right. It is sometimes a challenge when you're working in an environment that is predominantly do more, charge more, generate more revenue, et cetera, to get these ideas to stick immediately.
So, Vicki, you're going to say, but this time it's going to be different, right?
Of course. Well, I think, I was thinking about another thing besides this incentive to do more, charge more. It's also just the reality of the time constraints of what we have. So I was talking earlier about how the C-section rate is too high, and there's a lot that goes into that. And one of that is overburdened physicians who I have clinic every single day, my patients are delivering at any time. It's easier for all of us if we just do your C-section at 8 p.m. so I can get a full night of sleep to see all my patients tomorrow. So the incentives are not aligned necessarily for best outcomes. And so it is hard to change a system, and a lot of people are very nervous about the idea of doing something differently because this is how we've always done it. But I think that ultimately, most of us went into medicine because we care about our patients and we want the best outcomes for them. And I think when you show that you can actually restructure a system so that you are happier at your job, you're making decisions that will help your patients, and your patients are happier with the care that they're getting, that actually will help. I mean, it takes a lot of talking and a lot of slow change, but I think it's possible.
Vicki, I want Vicki to elaborate a little bit, because she sees this opportunity to give the opportunity for women who don't have any risk factors for a complicated delivery to have a non-medicalized experience in a freestanding hospital-affiliated birth center. And she's been practicing, for more than a year now at Kaiser Permanente, where there's not a problem with incentives. Maybe, Vicki, you could sort of maybe not talk about Kaiser Permanente specifically, but just talk about, even in an environment where the incentives are aligned, what are the challenges in any reflections or things you'd like to share with people about getting obstetricians who are used to doing things a certain way to think about giving up, in essence, a lot of their current low risk deliveries?
Well, sure. So at where I work at Kaiser, we actually already work with midwives. And so midwives see our low-risk patients, and then we are there for any acuity changes, and then we manage all the high-risk patients. And unfortunately, our patient population in the US is also getting more high risk in some places. And so we have plenty of work on our own taking care of our obese, older, high blood pressure, multiple gestation patients, that there's way more work than there are providers. There is enough to go around. We aren't going to be losing patients by having them deliver and in a different space and transitioning them over. So I think that is one issue. And I think that the main concern from physicians about something like changing healthcare delivery is safety outcomes. That's the thing they care the most about. That's the thing that when I talk at hospitals about this idea, they want to know. And I think that based on this data from the UK and what we know, especially if it's close by, there is great evidence that the outcomes are just as good. In fact, it may be safer. So in 50% of community hospitals, there is no in-house OBGYN and there's no anesthesiologist. And so that's essentially a hospital that is functioning like a birth center, except it's a labor nurse, not a nurse midwife who's managing that patient. And then if something goes poorly, they call them in. And there's studies that show in California that less than 50% of providers are able to get there and do a C-section within 30 minutes. So we're already looking at an equivalent situation, but not as well coordinated. A birth center, the idea would be they were coordinated already within a healthcare system, and these women may actually get better care delivering in their birth center than in their community hospital with no in-house providers.
Okay. We welcome your comments, but in addition to identifying yourself, your comment should be voiced at the top of your license. Full competency.
I'm not sure exactly what that means. So Sarah Thomas at Deloitte Center for Health Solutions, and I have a lot of questions. It was a really terrific presentation, but I'll confine myself to two, and these are not these are actual questions and not editorializing. So the first question is, one of the things that I've been struck with in Oklahoma is the technology aspect. So one question is, how can technology enable and support some of these ideas? And the second question is to Arnie, and remembering your long experience with employers, great policy ideas, but can't employers just do this stuff right now with their self-insured population? And if not, why aren't they doing it?
Sure. So, thanks for raising that. Oklahoma did more than simply, pool the information. They also created a patient portal. So for the subset of patients who actually, had the motivation and interest in beginning to get a picture as to what was happening with, with their health and what the clinicians were thinking, there was an opportunity for them to participate. And there also was a means that they put together in Oklahoma for the clinicians to communicate with each other and via secure web format. So that I think that did make a difference. I think the challenge for most employers is that so few of them are, unlike the old days, are geographically concentrated. So there's some terrifically progressive American self-insured employer purchasers, but when I say to them, okay, let's now, why can't I attract Walmart or Boeing to essentially do something major in a state where they're not dominant, and they run the math and they go, well, we're running a benefits department, and there's only even if you're Boeing, which is one of the few companies left that has a lot of concentration, there's only maybe 4 or 5 cities where it would make any sense for Boeing to come up with a coherent collaboration with the other payers in the community. So I think the problem with the employers playing more of a role than, and the reason I didn't call them out is that their populations tend to be so splintered. Where that's not the case, for example, in the state of Washington, Boeing's playing a tremendously constructive role in the BRE Collaborative, which is a statewide attempt to begin to move the needle on care changes very similar to what I've described. But the problem is just dispersion of American labor forces and the decline of these gigantic manufacturing plants that used to allow companies like GM. You get GM in the old days. When we used to if we get GM, Ford, and Chrysler together, which we used to be able to do, in some of my prior work, the health systems came to the table and basically asked, what would you like us to do? But there's so few communities where that's now possible.
So we're arguing for concentration in order to inform healthcare. Well, that'll be our second panel, I think, on that area. Did I see any back there?
Good morning, Ian O'Connell with AARP. I'm wondering, I know in Washington, D.C., we love talking about policy change, healthcare, and money, but I'm wondering about these clinical changes and how they impacted your patients' quality of life, in terms of medication adherence. Maybe, we over-medicate dementia patients, and my wife and I used a midwife, and we, we're right out of the hospital in 2 days, and she was back doing yoga again. So I'm just kind of interested in the impact on patients with these clinical changes.
Well, Nick, it's maybe self-evident. Nick, maybe you can start with,
Sure,
what does it mean for not just the patient, but also the family when you've essentially insulated a patient from an episode of delirium and therefore reduced their prevented and accelerated cognitive decline post-hospitalization?
Yeah, unfortunately, it's an all too common event these days. So most people can relay a story of a loved one who's experienced an episode of delirium, especially older adults, and it's a harrowing experience for the caregivers or the loved ones around them because it's a very acute form of cognitive dysfunction. It can be very scary. It can be traumatic. So the quality argument for prevention of delirium, aside from what we know from the clinical evidence, there's also just a patient experience and kind of the family experience that is huge. And I think, the same, I didn't speak a lot about this, but hospital at home, our team had the chance to do ride-alongs with Presbyterian Health System, who has one of the most robust forms of hospital at home in the country, and seeing the quality of care delivered at home for these interventions, and seeing the patient experience, not just, again, the patient, but the caregivers, being able to, receive that kind of medical intervention the House, and knowing how much benefit that provided to a loved one, not having to drive to the hospital, try to find a parking spot, show up, and the clinician had already done rounds, and so they didn't get to ask their questions. And when you really consider the whole patient experience of hospitalization, anything we can do on that front, particularly for an older adult who has cognitive impairment and the problems that already go along with that and the burdens that come along with that, it's a massive improvement.
We'll take another question or two before going to our next panel. Jim?
Hi, I'm Jim Capretta, colleague of Tom's here at AEI. So I'll try to be as polite as I can be, but
We appreciate that.
yeah, but at the same time, maybe raise some cautions about whether or not how exactly this could be done. Again, to your second bullet there, Dr. Milstein, it says we have much greater clarity on the supplemental changes required to accelerate adoption by clinicians. Candidly, I don't have greater clarity, so I'm wondering if you could, who's going to do what to change the incentives to make this happen.
Okay, maybe we can go. I'm going to just go back here. So, first of all, right now, when I'll just CMS. When CMS gets an application for a state for a Medicaid waiver, right now there are specifically there could be some additions to the checklist that CMS applies in deciding to grant a state waiver, and one of them could be for example actually all three of these ideas could conceivably be on the checklist. Is the state have they applied for and have they got together an all-payer claims database so there can begin to be clarity in their state as to which teams are doing better and thereby help teams that aren't doing as well on value appreciate where they rank and improve across all payers. Secondly, why not have on that same checklist whether or not the state itself has instituted legislation to begin to orchestrate some form of coherence across the payers that the state has some influence over, not the self-insured employers, but certainly the state licensed insurance companies and the Medicaid program and the state employee program, so that we get a little bit of what the Oklahoma doctors appreciated so much, which is some coherence of messaging as to how value is going to be measured across payers, and a little bit more coherence in the nature of the reward for either movement on value or superior value. That's a concrete illustration. Begin to modify the checklist that CMS uses to encourage states to cohere a little bit more with CMS around the same kind of measurements and incentives that were illustrated by the MACRA in the MIPS component of MACRA and the APM component of MACRA.
This would be a waiver with mandates, in other words.
Oh, a waiver with a longer list of yeah.
Well, we've got everybody piling on. Jim used to be on one end in terms of seeing these applications. My colleague Joe Antos was at least brewing some of them in an earlier age.
Still am. So, Arnie, you made a good point that without concentration in the demand side, you're not going to get push from there. So your solution seems to be, well, the federal government can't regulate very well, so let's have the state government regulate.
Yeah. Let's encourage the state to coordinate better with CMS.
It's still regulation. But what is it other than regulation that's going to get big insurance companies to move? I think you need to address that one too. I think there are factors there, but you haven't addressed it.
Sure. So right now, the outside of the exchanges, there is not clarity as to whether a given health insurance plan, on a truly a risk-adjusted basis and adjusted for the actuarial value of the benefit, there's not intense value competition for outside of the exchanges and Medicare Advantage, but there's not intense value competition among our health insurance companies, and I really defer to you, Joe, as to can you imagine a form of something that a policy change that you would not classify as regulation that would begin to make it easier for American consumers and the smaller and mid-sized employers that use fully insured plans to begin to compare on an apples-to-apples basis on an apples-to-apples basis, the value provided by health insurance offering A versus B. We don't right now. There's it's almost impossible. I mean, most of us don't have a clue as to on a risk-adjusted basis and benefits-adjusted basis, actuarial value-adjusted basis, which plan represents the better value.
Right. I'm a big fan of data collection, absolutely.
Okay, all right.
As long as it doesn't produce information, right?
Well, no, if there's a reason to then figure out what that data actually tells you about your own operation, then that could make a big difference. I don't want to say it makes a big difference because it doesn't have to. This is something like an argument for the kind of state regulation that Maryland dreams it's doing. I'm not so sure that it is. I'm associated with Maryland's rate setting commission, and we're moving to a system that's supposed to be total cost of care. The one thing we've done right, I think, is to create an entity that collects data, and we have active participation by hospitals. And the reason why it's hospitals is because they have the capacity to produce information. Doctors, on the other hand, especially independent community physicians, really don't have much capacity at all. So I think there are major gaps even in the data you can collect that I think are critical to this whole point. Anyway, enough of my editorialization.
Yeah, but that's why I brought up the Oklahoma example. Here's some smart, in a state that isn't known for for large public investments in anything, that made this work. And they put together a health information exchange, which is a federal program that I think holds a lot of promise. And they, for the first time, gave clinical teams a clue as to how they were doing, and that same model, I think, could, per the earlier question, apply to being able to help consumers, make it easier for them to compare insurance plans. Right now, it's if you're not an actuary, it's virtually impossible.
Well, all right. We have one more question back there.
Hi, I'm Shannon from MedPage Today. I just had a question in terms of scope of practice. Can you talk a little bit more about how that would change with each of these ideas?
Well, each of these ideas, meaning, you can pull ideas out of each of these. For example, take the example of freestanding birth centers in which the lead clinician is a midwife. In some American states, this works great. In other states, it's forbidden. The independent, practicing nurse midwife. Take Dr. Brady's example of offloading a lot of clinical decision making from doctors to doctorate level pharmacists once the doctors made the initial, therapeutic decision. There are plenty of states that allow that and plenty that don't allow that. Those are illustrations of opportunities in a lot of American states to begin to modify scope of practice laws in ways that other states are already making work and generating the kind of returns that Dr. Brady described.
Do you know how many states allow independent nurse
Well, we're kind of getting into specifics, but they could actually, in some places it's can they practice independently, or in other places it's do they have an OBGYN who oversees them. So actually with a birth center model, if there is an OBGYN who's the director of that birth center, it doesn't matter in that state, but I think that it does matter in the minimum qualifications that midwife has, and I think that someone who is leading this should probably be our certified nurse midwives have the most robust medical training prior to becoming midwives, and I would argue that makes sense in terms of who should be running these birth centers. So not necessarily people who just sort of apprentice themselves to a home birth midwife and then start practicing without any formalized medical education. So that's kind of where I see the differentiation.
Yeah, the other point, the reason I also put that in there wasn't only related to these three models you heard about, but basically 60% of American healthcare spending are labor costs. And though there were illustrations in these presentations of opportunities to, by increasing scope of practice, to improve value, these three care models are not in any way illustrative of the full range of opportunity to, if there were greater state flexibility in scope of practice, to begin to take that 60% of healthcare cost of production that's associated with labor cost and reduce it.
This morning's news are speculations about a reinvented CMMI and innovation, although we don't know who's going to be innovating and who's going to be improving it, so I suppose that may be another area you can go to. We've tried, well, you can have smarter regulation in payment or dumber regulation in payment. We've tried the latter. We might want to try the former on occasion. It's only an experiment. And so despite some skepticism being voiced here, it sounds like this is something we should do. And despite even more skepticism, it might be something we can do. The larger issue is, will we do it? But please thank this wonderful team of researchers for bringing this forward. We're just only going to take just a couple of minutes to bring our next panel up, and we'll be ready to roll in no more than 2 or 3 minutes. Welcome back, everyone, to the second part of today's conference. We're going to focus a little bit more on competition and why the innovation and change we seek doesn't seem to always come about. Just as a postscript to my opening, I used to use, although we don't have it digitally enhanced today, just to formally declare the ceasefire. I always like to salute Hiroa Noda, the last Japanese soldier to surrender in the Pacific. It only took 29 years for hostilities to be ceased. He passed away a couple of years ago. It might be a model for some folks currently, but that's only a slight suggestion. We have two I would say, although they're well recognized, less conventional thinkers who are willing to break down some boundary lines in thinking about healthcare delivery and competition. Kevin Schulman is a professor of medicine and a professor of business administration at Duke University. He's associate director of the Duke Clinical Research Institute in the School of Medicine, which is the country's largest academic clinical research organization. Widely published just about anywhere you want to look, except on the comic pages, I suppose, but on the academic side. And Kevin received his MD from New York University School of Medicine and an MBA with a concentration in healthcare management from Wharton, and also residency in internal medicine. Bill Sage gives us the other dimension of Stanford East. I didn't looking through your background because you've got both your JD and MD from Stanford after going to Harvard. So we continue the Stanford Duke collaborative here, I suppose. Bill is a authority on health law and policy. Teaches at the University of Texas at Austin. He's everywhere, but among other things in the National Academy of Medicine and the Board of Healthcare Services of the National Academies. Written tons of articles, edited a number of important books, including the Oxford Handbook of U.S. Healthcare and Law. And Kevin will be talking about why we're not getting the change. We get innovation, we just don't get disruption, I suppose, in healthcare. And Bill's going to talk about the problems of health law regarding health policy and other issues as well. So after we first blame all the lawyers, we can move on to do some other stuff. But Kevin will start us off.
Yeah, I'll definitely blame the lawyers, so no problem. I think, I want to talk to you a little bit about my perspectives actually teaching in the business school and looking from the business school back to the healthcare system. And I also want to recognize that we've had a policy environment the last couple of years that's been very focused on hospitals. Our ideas, a lot of the ideas that we've been circulating in the policy community is that we want the behavior of hospitals to change, or health systems to change. We want them to change in very specific directions. And so I think it's really important for us to understand, is that occurring? Is that even possible? And so I like to start with this slide. We just talked about auto industry a couple of minutes ago. And think about the idea of business architecture. Right? At the underlying, the reason why organizations are successful in this country is that they produce predictable results. In fact, as the leader of an organization, your job is to make sure your performance next week is the same as it was last week. That's a really, really big challenge. And so organizations are built to produce predictable results. As a board, we look to make sure our organizations produce predictable results. And so we're a finely tuned machine to make decisions to enable us to make predictable results. And so we have walls around what's acceptable and what's not acceptable in an organization that really kind of looks like this. I mean, this is about as predictable as any process can be. And this is the optimal way we would organize a business in the United States right now, or optimal way to organize the hospital. And so to say we want change from this, what's the change you want? Do you want us to take one of the robots out? Do you want us to change the factory? Do you want us to break this up into little different units? That's very, very challenging for an organization. I'll show you some data to support that. But that almost is a concept that's not feasible. So what kind of change do we get from these organizations? And I'm going to pick on our colleagues. I get from Duke, so I get to pick on UNC. UNC in Carolina has just announced that they want to merge. Bill Roper was CDC director, I think, in the Bush administration. Can't be any less, there's no one in the country who knows more about health policy than Bill Roper. And he decided to merge into a $14 billion organization that would take up about a third of the state. And in an interview at the newspaper, the day this is announced, this is what Bill and Gene Woods said that they wanted to do and the reason why they wanted to merge. He wanted the partnership to give them leverage to negotiate better deals with insurance companies. Okay? On the newspaper, one of the country's leading experts in health policy said he wanted to merge to raise insurance prices. Okay? I just spent the whole day with the people. I was saying, I'm not saying this, he said it. And then the other interesting thing is they also want to negotiate over vendors. And so this is a really interesting concept. It's a little more subtle. But when you think about it, they already belong to group purchase organizations. What difference does it make if they're a $10 billion organization, or a $5 billion organization, or a $15 billion organization when they go to Premier as part of a purchasing organization? So what are the vendor leverage that they're going to get? Well, one of the really close to home vendors is the physicians. Okay? The physicians are really the only ones that independently contract with the hospitals. And so here's the statement that basically the health system wants to beat up on the health plans and beat up on the docs to improve the bottom line for the hospitals. Okay? And this is the organization that we want to change. Market power is one of the major underlying reasons why healthcare costs have increased in this country. This is Jamie Robinson's work. But basically, if you go to a physician who owns their own practice, you cost the health plan about $3,000. If you go to a physician that's practice is owned by a multi-hospital system, you cost your health plan $4,700. We just spent 8 years telling the hospitals to integrate with the docs to produce better quality care. We were really concerned about that, Barack Richmond at Duke and I, and we said in 2011, this may or may not have an impact on Medicare, but it's going to have a huge negative impact on the private market by driving up prices. So in 2016, after there had been 3 evaluations of the first rounds of ACOs, we got a chance to say, we told you so, in a pretty scathing way, and sent this paper into JAMA. JAMA said, well, this is too scathing, we can't take it. Would you let us have a debate? And the interesting thing was Elliot Fisher, who was the person that was proposing ACOs with actually no evidence to suggest that hospitals and doctors could ever work together to reduce costs, actually backed off and said the evidence is that physician-led IPAs physician-led ACOs were the ones who were having an impact. Physician-led ACOs look like Arnie's experiment in Oklahoma, where the docs and the health plans get together to beat up on the hospitals. That sounds a lot like managed competition for 1993. That sounds not a lot like a hospital-led ACO. Clay Christensen has this really elegant idea of centralization and decentralization of industries. He talks a lot about how the technology industry is centralized. If you ever, this idea that we'd have, the computing power got centralized, and then as an industry, we decentralized both the technology and the business architecture. Okay? Why is it that we're walking around with a phone that has more computing power than the Apollo 11 capsule and much cheaper than the computer that was in the Apollo 11 capsule? Well, that's this magic of organizational innovation. Firms come up with new business models. And then those new business models, you don't go to a store, you don't get a salesperson to buy a computer anymore, you don't go to a specialized computer store to buy a computer anymore, you go to the phone store, okay? Those business models, the overhead of those business models, the cost of that sales force, the entire business architecture has to change to enable technology to give you a different level of performance. And so it's interesting, what are we doing in healthcare? We're concentrating power, market power in healthcare systems that are controlling all the downstream decentralization of healthcare. One quote I would have about the last presentation was the hospital was going to own the birth center. Well, the hospital already owns 10 beds. Why do they want to build another 10 beds and have their 10 beds in the hospital be vacant? And what's the price going to be? Well, they're going to charge the same overhead price. So yeah, it's a freestanding ambulatory surgery center. If nobody else owned it, it could cost you X, but if the hospital owns it, it's going to cost you 4X. Okay? Because this is the idea of the hospital controlling decentralization. And I actually asked Clay about this. He didn't have a great theory about this, But in fact, we'll see decentralization, but not see the cost savings if we don't have transformation of the business model and we don't see migration of ownership of services in other directions. Now, one of the fun things we've been doing the last couple of years is asking, what is it? How are these systems so effective in raising their prices? What is the tool that they get to be able to say, the Roper says, now he owns these two health systems, how can he raise the price to Blue Cross Blue Shield of North Carolina? We've been complaining about monopoly insurers. When you saw the mergers last summer of the 4 insurance companies, you had Aetna and Cigna, whichever one they wanted to merge with. One of the arguments was the hospitals have so much market power, we have to merge into 3 national insurance companies to have any chance of having leverage. Well, how do they have so much leverage? Besides the network, one of the ways they have leverage is through something called charges. Okay? And this is an absurd system that doesn't exist anywhere else in the world, where you go to the hospital, there's no price, you leave, and we send you a bill. And we send you a bill for, we go like this, and we say, how much should we charge today for an angioplasty? Maybe 50 grand or $100,000. We send you a bill for $100,000, and we expect to collect that. And if you don't want to pay us, and you and the insurance company don't want to pay you, we'll take you to court. And under a legal, I'm sitting next to a lawyer, but under a legal framework called implied contracts, the crux of the implied contract is this idea that if you don't have a contract, the court's supposed to impute the market price. It's not supposed to impute the price by either of the parties. Okay? And the problem was healthcare is so complex, judges have no idea what the market price is. The same way patients don't have an idea what the market price is, judges don't have an idea what the market price is. And in some jurisdictions, the judges, when the hospitals are well represented by really good law firms, said, well, that's the best estimate we have of costs. And so if you're a health plan, you could actually agree to take 95% of whatever I'm going to charge you, or you can go to court and you're going to lose, and I'll be able to collect 100%. So our idea here is undermining the market power. We don't have we could stop mergers before they happen, and hopefully we'll stop this Duke and Carolina's merger before it occurs. But once it occurs, there's really very little ideas of how to undo mergers in this country, especially these health system mergers. We could effectively undo their leverage if we didn't allow them to get charges. So that's the argument we made in this paper. And Arnie's a co-author of that one too. So I love to look at this idea from Google. What used to be Google is now called Alphabet. And it's hard to read this, but this is Larry Page's letter about why they reorganized their company. Obviously one of the most successful companies in this country, one of the top 5 in market value, restructures, gets rid of his name, restructures his Alphabet, and basically the argument is to improve the transparency and oversight of what we're doing, making Google even better through greater focus, and hopefully as a result of all of this, improving the lives of as many people as we can. And if you read through all this, we don't have time for it, but basically, this is what we want healthcare to be. There's nothing, that we would have said about healthcare reform that isn't contained here. And what's Larry Page talking about? An organizational restructuring. Okay, changing the business model internally within his organization as a way of empowering the change that we all want from the healthcare system. It's very different than the robots. Can this occur in healthcare? So we've been arguing about changing healthcare systems now for 8 years. This idea of moving towards some type of value-based payment or capitation payment was written about in 2010. Okay, we're 6 and 7 years on, so we got an idea. How much? First off, the question was, how much would it cost you as a health system to move from fee-for-service to capitation? You've had 6 years to look at this. How much would it cost you to do that? And so we started surveying chief financial officers. Getting them on the phone is really, really hard. This is the first of the 5 interviews that we've now up to 10. The first 5 interviews, no one can answer that question. 6 years in, the chief financial officer of the largest academic health centers have no idea what would it cost them to actually change their business model. So we said, great, well, here's your budget, okay? Here's 20 line items on your budget. Which of these line items would change? And they're like, oh, we could tell you that. And so they basically went through this, and we told us how much they would change. And here's the graphs, and you don't have to look at what they say. But of these structures, across just 5 different people, There's no consistency whatsoever at all. Okay? They were guessing. There's no planning going on to move any organization from here to the nirvana that we all talk about. So this is what this looks like in terms of innovation. Most of us talk about innovation. We talk about innovation as a big game. And the question is, can this actually occur? Would you let these people play with the robots? Okay? And if you're the chief executive of a healthcare system, you would say, absolutely not. You would never let these people anywhere near the robots. Okay? Look at them. All right? But think about the value creation that's come out of the two of these. If we exclude Tesla, where's all the value creation in the U.S. economy? Okay? It was the innovation agenda. Okay? And so we're sitting here crippling ourselves because the innovation agenda can't play with the robots. And yet we're wondering why we don't get this innovation in the U.S. economy. So we just actually, one of my students, this is her idea, wanted to do a survey of chief innovation officers. Of the top 40 healthcare systems, 32 now have chief innovation officers in the United States. They're going to implement this change that we all want. Again, massive change. These systems are multi-billion-dollar organizations. Of the chief innovation officers, 13 of them said that they were strategic. Their role was strategic. If you had to use one word, it would be strategic. And each of these people have a massive budget to make this change from fee-for-service to capitation and value-based payment of $3 million. Right? Which is about as much as we pay to change the color of the brochure of our health system.
Priorities.
I think one of the things when you think about all this stuff and we think about the birthing center, we really have to think about innovation architectures and go back to ask the question, is this innovation we want to bring something we want to do with an existing system, which is making them change, which means we have the legacy cost of the old, take the birthing center, we have the legacy cost that we already have a unit, we have the cost of the new unit, or is this something we want from a greenfield? We just build it as a freestanding center across the street. Why you can't admit a patient from one facility to another without owning the facility is beyond me. But we're not doing enough to think about greenfield and the success of greenfield organizations out there. This is the last week's New York Times, and basically is focusing on a startup slump, and big business may be to blame, and it blames the technology companies. I would posit that one of the places we're lacking in organization is in healthcare. We're 20% of the US economy, and I will tell you, as a founder of a startup company, selling to a health system a new innovation is a fate worse than death. It's a really kind of critical issue, the relationship between organizational innovation and disruptive innovation. So with the business literature and outside of healthcare, we're looking at the magic of disruptive innovation, Uber, what Apple did to the music industry over and over again. And that actually has two effects. One effect is obviously the new innovation, but the second effect is on the incumbents. Okay? How do businesses change? I like to say, the CEO, when they wake up in the morning, has two choices. One is to transform their organization, and the other is to play golf. I won't say anything. So I'm going to have to use a different analogy. We've spoiled it. But why would the CEO ever not take the golf day instead of coming to work and doing the hard thing if they didn't think somebody was going to put them out of business tomorrow? No one's put anyone out of business in healthcare for forever. Okay? The handicap of every CEO in healthcare should be really good. So how do we transform the healthcare system? So one of the things we have to go back with is really recognize that our IT efforts in healthcare have been mostly a miserable failure. And why was it a miserable failure? We didn't have an economic argument about what we were doing. And so I had to write a course on health IT and strategy at Duke. And the course actually, I said, we want to use technology to improve quality, reduce costs. Where have we done that in the US economy? Here are 10 different ways in which we've used technology to improve quality and reduce costs in other industries, and we've used none of them to architecture IT in healthcare. You guys might recognize this guy. What if 50% of healthcare was delivered by mHealth technology by 2025? So if you want a big idea, this is our big idea. I mean, to some extent, this is what we have to have the productivity to really address, to go look at Medicare and the future growth of Medicare, and you'll lose sleep every night. This is the only way we're going to get there. And to some extent, the technology is all here today. This is really a business model issue. We could easily incorporate almost all the innovations that the teams came up with through this technology. We don't need to go to the healthcare system and tinker with the robots to get it. Connectivity is a critical part of that, and I think we've totally undervalued it. So here's from Singapore, the innovation that they have. One patient, one health record. Okay? Such a simple concept. What's the highest value of information technology? If all of your healthcare information is available to you at the time you make a decision. Okay? Our fellows moved all around the world. These fellows moved all around the world. I've moved all over the place. Just think about what it would take for you to get all your health records. Okay? How many months would it take you to get all your health records? What value is that information to you? Even after Duke spent $700 million on Epic, it still doesn't answer this question. And then finally, we have a real challenge that we're developing technologies that have huge value. This is out of Verily, Google's life science group. Now they could actually read pictures to screen for diabetic retinopathy. Will the FDA allow us to develop technology to substitute capital for labor? Okay. All right. The FDA is scared to death of taking the doctor out of the loop because that's been their mandate for years. But in fact, the only way we're going to get economic value out of this technology is to substitute for the doctor. And this is a great one to do that. My job was to kind of wake us up to the opportunities, but it's this combination of both the technology and opportunities and the really fundamental question of the business model. And how do we get transformation of the business model? Because that's, at the end of the day, when we're going to see value creation. So thanks.
Thank you, Kevin. I feel really upbeat after that one.
I usually do this after 2 glasses of wine.
Now we're going to turn to, we've got a battle going on. We don't know whether we should blame the hospitals or blame the lawyers. And we should blame the hospital lawyers. I think will take care of everything as a synergy on that front. Bill Sage is going to talk about kind of both law and policy and the larger situation of competition and what I guess you call accreted law, which I guess secretes money to the people who have accreted the benefits along the way. But let's have Bill go at it. We apologize for not having Bill's slides available. Some technical policy.
No one told me this.
Oh no. That's what I mentioned last night, but that's okay. Everybody has hard copies of the slides, and they'll be posted on our website, but it's not interactive here due to some protocols beyond my control.
Nobody told me that. So
you need a copy of his slides. Always a good idea. I was also handicapped because I was going to have the Steve Martin slide with an arrow through the head for the triple aim, so we're all equally limited in that respect. Sorry, I thought I made that clear, Bill.
I thought
so. We're going old school in terms of people knowing what's there, but not having the visual enhancement.
Okay, old school's fine. We'll make do. I'm happy to be here. Kevin and my presentation turn out to be complementary. I was going to say through Tom Miller's brilliance in advanced planning, I now am sensing there's an element of luck involved. My first slide was the disclaimer you often see here in Washington, D.C., which is that the speaker's comments are only his own and not his organization's. Then I thought, we're all academics here, so that's a silly type of disclaimer to include. In fact, I get to say as an academic exactly what I believe with no constraints known to me. I did provide you with some, I think, useful disclosures. One, I'm a Democrat, and I'm a big supporter of the ACA. Two, I really believe in market competition as a way to get lower prices, better quality, and higher innovation. And then I'll just read the third one. The author would like the U.S. to stop wasting $1 trillion each year churning overpriced, often useless services and medicalizing social problems. So I speak with some passion. I'd also point out in your slides that the $1 trillion is written out with a 1 and 12 zeros. The actual number of zeros involved in the number 1 trillion is something that people seem to skip over in many discussions of expensive areas like healthcare. All right, the slide that follows that is called Having It All and is a simple summary of the first 4 titles of the 10-title Affordable Care Act. Titles 1 and 2, taken directly from the law, are about health insurance. But here's what's important. Title 3 is not about health insurance. It's called Improving the Quality, Efficiency of Healthcare. It's about healthcare services. And Title 4 is neither about health insurance nor about healthcare services. It's called Prevention of Chronic Disease and Improving Public Health. And that's not about either the insurance or the care side, but about underlying health. And everyone in this room now knows that health care is only one and certainly not the dominant input into health. And when I teach about the ACA, I tend to use visual aids. And the visual aids are there for you on the next 2 slides. And I'm holding up a page of visual aids on the insurance side. And what I'm actually showing you is how the ACA simply solves the 2 major problems of health insurance in the United States: non-insurability of people in private markets and unaffordability of coverage. The solution for unaffordability of coverage, simply put, is money. The solution for non-insurability I display here as a magic wand. And indeed, the ACA, basically for insurability, waves a magic wand over the uninsurable US population and declares it to be insurable. This is perfectly plausible if, in fact, everyone can be insured. And the fact that we have spent the last 7 years arguing about, contesting, litigating, and partially dismantling these fairly intuitive solutions to problems involving health insurance is heartbreaking to me. But that is not all. On the next page, you'll see the 2 visual aids for Titles 3 and Title 4, the healthcare services and the health carts of the ACA. And these are not pictures of the solutions, because indeed, I could never find a picture of a solution. Kevin, your smartphone mobile health probably is the closest I can get to the picture of a solution for Title III. These are pictures of the problems, and they're 2 very similarly shaped objects. The picture of the problem of overpriced, often useless, highly wasteful healthcare delivery is a ballpoint pen, the most expensive medical technology in the world. Something used by hundreds of thousands of American physicians every year with the best of intentions, but against markets that don't work, poor information, and bad coordination, end up spending on a discretionary basis over $2 trillion, and that's 2 and 12 zeros, of our collective money each year. And that's horribly wasteful. And the image for Title IV, you can mentally extract 1 very long French fried potato from this unlabeled red box, and you can compare the 2 objects. They're similarly shaped, and that, of course, represents the underlying poor health of the US population. And the ACA's ambition in simultaneously tackling insurance coverage and healthcare delivery and health is extraordinary and noteworthy. But it's not just extremely ambitious. It has an evidence base. And there's 2 things that I really want to convey during this talk, and I'm going to highlight them for you, and this is one. The way we think about health policy in this country, the way we learn health policy, has changed markedly in 20 years, and people don't really notice. And partly they don't notice because years ago it was 3 things: cost, access, and quality. And today it's 3 things: improving the patient experience of care, improving the health of populations, and reducing per capita cost, going from an iron triangle to a triple aim. And we often just don't step back and think what a radical reframing of the problem, and therefore what a radical reinvocation of potential solutions this transition represents. The access, cost, quality description of health policy made plain that in order to optimize parts of those 3, you would have to de-optimize another part. You could not have it all. And I provide in the handout a quote from Bill Kissick, a Penn physician now deceased, who was present at the creation of Medicare and federal tobacco policy and a number of things, and wrote in the 1990s that no society in the world has ever been or will ever be able to afford providing all the health services its population is capable of utilizing. that version of health policy subject to constraints and tragic choices, driven by improvements in medical technology, was the way I learned health policy. That is not the way health policy largely exists today. If you flip the page in the handout, the triple aim is not about tragic choices. The triple aim is about simultaneous improvements in all three parameters. And the only way that can possibly be true, which it is that we've spent 20 years learning how far off the Pareto frontier our current healthcare system is, both in the inefficiencies and wastefulness of care delivery and in the gains left on the table in underlying health improvement through largely addressing social determinants, largely in non-medical ways. And I've provided you a slide which I call Game Changer. And this one I won't go through so much as hope that each of you in your own policy and political work will just think about this important transition from an on the Pareto frontier iron triangle formulation to a way off the Pareto frontier decentralized improvement model when you think about political proposals in health reform. Because whether you are an adherent to health savings accounts models of consumer-directed care, or whether you're a longtime believer in managed competition principles, or whether you even want to invoke a single-payer framework and Medicare for all, as I've tried to describe concisely in this slide, the tasks that each of these big-picture policy frames would have to deliver on are actually very different under a triple aim paradigm than they were under a tragic choice paradigm. And I would just really encourage everybody in whatever you do to think about that when you encounter new policy proposals. Now let me get to the second big point of my remarks. So I've given you a couple of slides that are titled The Slow Pursuit of Healthcare Value. This is the part, so Kevin, I agree with really everything you said, but one of your omissions is an omission that I have found so common in the managerial innovation space around healthcare. So look, we all kind of know where we need to go in healthcare. There has been a pretty solid kind of medical and social medical consensus on that for years. And so what I've provided you are kind of the safe, effective, patient-centered, timely, efficient, and equitable goals articulated by the Institute of Medicine in its Crossing the Quality Chasm report more than 15 years ago. So that's really settled. We know what we want the system to be. And then on the next slide, I've given you one managerial formulation. For ease of exposition, I've given you the Harvard Business School Michael Porter version rather than the Reggie Herzlinger version, the Clay Christensen version, the Arnie Milstein version. There are many versions out, but they have a lot in common, the Kevin Schulman version. And I've given you things about, organizational integration, use of IT, economies of scope, other information systems and associated payment innovations. And although there are some differences, for the most part, it's a pretty clear story. So ask yourself the following question. If for 15 years we've known where we want to be, and for close to 15 years we've known how we're going to get there, why aren't we there? And let me offer an answer to the question that, frankly, nobody ever seems to mention. And I say this again as a Democrat and ACA supporter, but someone who loves markets and someone whose deep expertise over the course of my career is in health law. The problem is accreted health law. And the metaphor here is not endocrinologic. There's no secretions involved. It's actually geologic. And you'll find the geologic metaphor come back towards the end of the talk, where I'm really going to make this about rocks rather than about cells. And here I've sort of provided you on this slide a list, which I also won't try to unpack for you today, of all the ways in which a century of physician professional privilege, regulation, both legislative and administrative, and a whole bunch of very generous and selective subsidies have created the system that we've been in for half a century and can't seem to pull our way out of. And the way I encapsulate this when I talk about it is think about the doctor and the patient, that single physician-patient dyad, and think of all the things you'd like to have that represent. And as medicine improves, think of all the new things that you want that doctor to be able to provide to that patient, whoever that patient might be. And then realize that the legal system we've created around healthcare in the United States is basically created by multiplying that image of the two people a millionfold. And we have created a system, which is not a system, based around extrapolating one doctor and one patient to the entire United States. And frankly, it just doesn't work. So, what are the consequences of having this accretion of health law? Well, are all the barriers to competition and all the barriers to innovation that you could imagine coming out of that. So I've listed a bunch here. Fragmented production, minimal price competition, so many barriers to competitive entry, needlessly small geographic markets, buyers who are also almost always sellers and take a cut while they're doing it. Automation that never decreases labor costs. Your point is actually on my slide. Because we've imagined almost every healthcare innovation as fitting in some metaphorical doctor's black bag, which is huge and priceless, but is extracted by the doctor to use on the patient, as if we're back in that dyadic model. We have created legally in this country a system that makes it almost impossible for people to take care of their own health. Think about that for a minute. We have large insurers and we have large providers, and their financial and organizational and reputational interests are almost always the same. And we have constrained our innovation to match our highly stylized and inefficient production processes. And then sort of the piece that Tom Miller invited me to come here to talk about, but in the interest of time, I'm just going to tell you exists but won't go into the details. We've actually changed the healthcare product. And I am an antitrust lawyer. And whenever in the sort of policy sense rather than the enforcement sense in an individual case, I'm asked to consider, how active should antitrust law be, my problem is always that antitrust law assumes that a consumer is buying a product from a producer. And if the product is wrong, chances are the antitrust intervention is going to be wrong too. And what we've done with healthcare products, again, because of law, is the things we trade in are not things that any rational human being would want to buy in an advanced economy. We trade in professional process steps controlled by physicians. We trade in isolated inputs to those process steps. We don't really trade in risk-bearing insurance. We trade in a whole lot of claims processing and administrative services. And what we almost never have is the assembled product with a warranty that would be intuitive in any other advanced consumer industry. Medicare is doing these bundling projects. I support it in concept. When I see the details, I blanch, because what Medicare has done is proxy everything that might be in a treatment of a hip fracture or long-term osteoarthritis in the hip. What Medicare doesn't do is just buy that service, buy that product with a warranty from someone. They imagine all the things that would go into a television set. They don't go out and buy a television set. And that's a result of all the legal accretion that we've had over the time. How much time would you like me to take remaining?
10 max, 5
10,
minimum.
okay, if I have 10, I will continue, because I really do want to talk about why the ACA is far from perfect. And what I think about as the omission in the ACA is not about dealing with insurance. It's not about at least flagging the problems of healthcare and health. It's the ACA's unwillingness politically to assert that this was a national intervention. And so I've said the missing piece was any sense of solidarity, any sense of we're in this togetherness. And then I've kind of given you what I would have liked, a little graphic, where we don't have Obama and Obamacare. What we do have is AmeriCare. We have something that conveys.
If you're going to talk about solidarity, I might have to cut off your time.
Yeah. I'm going to talk about solidarity for one specific reason, which is to get us to the French fry, to get us to the problem of underlying health. Because if one is going to do the dramatic re-regulation / deregulation of the healthcare system, at the end of the day, one wants to make two sets of investments of the returns. One set is to put private money back in private pockets and let people spend it however they like. The other is to make certain collective investments in making our society better, which often involves making our health better, which really does involve in collectively investing in social determinants. Is that okay? So, I've provided you with a couple of the CDC obesity slides, encapsulated in the following conclusion. In 1990, there was not a single state in the United States that had as much as 15% of its adult population obese. Everyone was under 15% adult population obesity. In 2010, there is not a single state in the United States that has less than 20% of its adult population obese. That's an extraordinary change. I've then given you a wonderfully interesting black and white or sepia-toned photograph that I stole from Bill Dietz's presentation at the National Academy of Medicine last year that is a stylized picture of an American family in the late 40s, early 50s, I believe, in front of a year's worth of groceries. And if you look at this picture carefully, the only processed packaged food item in this entire photo that I could find is some cornflakes in the upper left-hand corner. And if you look at the next two pages, you will see the food environment today, which is nothing but processed packaged food. This is not stuff that medical care can deal with. This is a different set of investments. And then I've given you a slide with a very nice picture and book cover of my friend, the late Buzz Cooper, who wrote as his last work a book called Poverty and the Myths of Healthcare Reform. And without taking Buzz's side in his long-standing battle against the Dartmouth crowd, I want to point out that Buzz is absolutely right. The real drivers of ill health in this country, and to the extent a social commitment exists to provide medical care to those people, the driver of healthcare costs is poverty. And if you're not dealing with food environment, with educational investment, with poverty, you're not dealing with the social determinants of health. Which brings us to kind of the last couple of slides, and this is really where my heart is these days and where most of my attention is focused, and will explain kind of the interesting frame that I found searching through the available PowerPoint decorations for this whole slide set, is I wanted something that kind of looked like fracking. I think it was probably a transistor pattern or something from the semiconductor industry, but at any rate, to me, it looks like channels being broken into rock. And what I want to suggest to you is that at least conceptually, the project for the next 10 years is fracking healthcare. It's not repeal and replace. It's not just maintain and expand, it's recover and repurpose. It's recognizing all the trapped resources that are in our healthcare system. The healthcare geologists being people like the Dartmouth crowd and the people whose work underlies the quality problems, the safety failures, the pricing issues, the consolidation issues in healthcare. Those are the healthcare geologists. If you think about what we've done with energy and geology in this country, nobody ever thought that in a decade, and I'm not saying without risk, I'm not saying without potential harm, no one thought in a decade we could be a net energy exporter and have our own energy needs at much lower cost assured for the foreseeable future. Nobody thought it could be done until it was. And what if we could do the same thing for healthcare? So what I've given you in the last couple of slides is a sense of the engineers and the tactics. And if the geologists who found the trapped value are kind of the health policy crowd that we're all used to, and the managerial crowd as well, the engineers here are actually the people who can disrupt the legal barriers, who can really get into that deep substrate of how a century of professionally channeled, well-intentioned, multi-level regulation, professional privilege, and selective subsidy has locked us into where we are, and break those things up. They're not injecting high-pressure fluids to liberate oil and gas from shale, but they're doing the same in terms of resources that are both in capital structure and in operational value trapped within the healthcare system. And I've provided in sort of a list of tactics, and it's certainly not the only things you could name, the sorts of things it turns out Kevin and others and Artie have been talking about. Eliminating claims middlemen. Sorry, insurance industry, that's not that valuable. Disintermediating physicians, which doesn't mean not letting physicians be intellectually or compassionately in charge. It means don't put them in the middle of every single transaction you do. Because right now there's pretty much a doctor, a physician, who touches in either an operational or financial sense or an administrative sense every single transaction in the system. Ending blank check hospitalization, that's your charge master problem. Expanding self-care, reining in drug costs, which is partly actually reconstituting a real supply chain for pharmaceuticals, not the sort of supply loop we have right now that is largely self-enriching, and dealing with the important issues around incentives to innovate through mechanisms that are not limited to the unit price of product sold. Building a really flexible workforce that is not just physician to other profession, but is in many cases deprofessionalized and non-professionalized. And that's part of the bigger problem of demedicalizing social problems. The opioid epidemic, for example, is complex and tragic, but many of the paths in have to do with the last 20 years of cutting back investment in social services unless it's attached to medical services. And these are all just kind of examples at the tactical level. I've given you a slide I won't really read from about where this could go, but it reinforces the notion of both private gains and collective public investments, highlights some of the perils that do in many ways track both the local groundwater risks and the kind of climate global risks associated with fracking, and the ability of a massive industrial change to have its gains misappropriated in by a very small cadre of people rather than being shared widely. And then I give you sort of a little last slide. It says conclusion, can it happen? And I don't know if it can happen, but I certainly know that I and other people should try. So let me end there, and thank you very much.
Thank you, Bill and Kevin. We started today, I thought we were doing some mining, which was old school technology, and before you know it, we were fracking the whole thing in a very fracked up healthcare system. We've got the vocabulary of change is pretty well rehearsed. I mean, the slides all look about the same when you do the broad aspirations. So the question is, without, I guess, fouling the drinking water of the current incumbents, if we do some fracking, what are the ways to get from here to there? Now Kevin seemed to be suggesting, take a look, aside from the failures of business executives and their incentives, it's really a technological bypass. The only way you get out of where you are right now is to have something else delivered in a different manner in a way that beats the existing product lines. Would that be a fair characterization?
Yeah, so I think Bill's put the barriers in place, really nicely. It's hard. It's hard to enter into that market. And so one of the questions is, are there places that doesn't exist? And to some extent, that my interest in informatics actually is from that. Because the consumer side of health IT is actually not in that space. It's not in the rock, to use the same metaphor. So as a consumer, I could do lots of stuff with digital services in healthcare that right now aren't regulated. And so you could have some pathway there. Medical tourism we're not going to do as a country, unfortunately, but medical tourism is another unregulated space. So one of the questions is, could you find unregulated spaces and start there and begin to gain some traction there? So most of the time, so what we say is we want our health records, so we go to our hospital, get our health records or a portal rather than go to Apple or whatever. That might be changing now for the first time ever, but I think there's one opportunity there.
So if I can just comment on that, I think one can also realistically ask, what laws can you ignore? That can be done in kind of with the uber hubris of just ignoring laws and waiting for people to challenge you. I don't necessarily recommend that, but a couple of Ubers out in there in healthcare or Teslas out there in healthcare might go a long way to changing the conversation. The other is sort of a more modest way, and this is really to Arnie's points and his group's work. Within high-functioning organizations, to my mind, there is almost no reason to force those organizations to follow the established legal channels if there are far more effective and less costly ways to do business. And an ugly secret is that many very reputable, very well-considered healthcare organizations do not follow the niceties of legal prescription around scope of practice and such things, but being a little bit more explicit and welcoming about that when you have, I don't think you need all that many protections personally, because I think we have too many protections and that's what we need to get away from. But if you're doing it in clinical areas where the patient's goals and the patient's outcomes are really the prominent feature, the patient-reported outcome measure frame, I think, works well, and then just legal flexibility.
We'll go to your questions in just a moment. Appreciate your patience. One of the puzzles, everybody's in favor of innovation in healthcare. Pour money in, and we can kind of prime the pump in that direction. We want the newest, latest things. We have cost-increasing innovation, unlike other industries where we have cost-decreasing innovation. Is it just the protections that are doing that, or why does the healthcare sector tend to say, whatever's the newest and the best, we won't get rid of the older stuff, but we can always find something else that's more expensive for you that looks attractive?
Yeah, I think it's the part of it's this business model issue, right? Just by getting a better chip didn't get you a cheaper computer, okay? And so we're not getting a cheaper computer. What are those things? So if you put a new thing in Duke Hospital, I'll pick on Duke instead of UNC. So if you put a new thing in Duke Hospital, I still have all the old things. I still have all the legacy costs. And in fact, in healthcare, a lot of those legacy costs are huge buildings that they keep up all the time, and no parking garages. But I have all that. I have all the infrastructure from the insurance system. At Duke, we just calculated it costs us $20 to submit a bill for a primary care visit. Okay, it's almost $100,000 per primary care doc per year. Okay, so I'm going to put this innovation in there, and then through this morass, I'm not going to get any outcomes because it's an extra cost. The ACOs, these organizations, people can walk around and say, look at the performance of our ACO. Well, I still have the rest of the fee-for-service system there, and I have the cost and infrastructure of my new population health program or whatever. That's just an added cost. And so the greenfield idea that we have is if you started from scratch, you don't have any of those legacy costs, and you have some chance to work.
Which is why our new medical school at UT Austin, which is a greenfield, we've
Yeah.
never had, although UT system has medical schools and academic health centers scattered around Texas, including MD Anderson, there's never been academic medicine in Austin, and part of the reason I moved there was to launch that, and part of the attraction for all the people coming is that we do have greenfield characteristics. We don't have legacy costs with most of our facilities. We don't have a large operational labor workforce. We don't have the cultural overhang of physician dominance. When we do interprofessional education and practice with pharmacists and nurses and social workers and others, it's intuitive, and medicine's the newcomer and the littler kid rather than, the long-time dominant party.
Tom,
Yeah, go ahead.
but I also think we do have to recognize, we spent 8 years and more subsidizing the hospital-based model. We gave them antitrust exemptions. We give them 340B. I've never paid any attention to it. It's the worst policy anyone ever created. It's a total accident. But
Now that's an achievement.
But that's the biggest profit center at a lot of the hospitals in this country is a markup on cancer drugs. Why is it that the hospitals aren't screaming about the price of cancer drugs? Because they make 25% off it. I mean, you have this system where every single policy has subsidized the most inefficient way of delivering health care, and you've built that over and over again, every single mental model of people here in this town.
At least it's a consistent policy. policy.
Yeah, it is true.
Well, which is why I phrase it as no more blank check hospitalizations, because no matter what we've done with hospital payment policy over the last 25 years, with some modification for Medicare because of its administered pricing system, but certainly whatever's been negotiated when a private pay patient shows up in a hospital, it's basically a written blank check, and we've got to not do that anymore.
All right, let's see what comments, questions, or deeper concerns about people who say, how can I pay more, are out in the audience, or perhaps not. Well, I guess the system's working pretty well. Arnie? Wait for the microphone to come down. We're just recording this.
This is really just another proof point. It's something that, in 6 years on MedPAC, it's one of the things that really stuck in my mind. And maybe Sarah was around and can remember this, but we got interested in this question of what's going. How come there's a subset of American hospitals that actually, what horrific timing? Let's see here. There's some subset of American hospitals that actually are not losing money on Medicare payment and have good quality scores. What is going on there? And actually later when I got to Stanford, I launched a second version of the study that MedPAC first launched. And I think it's just one of the best MedPAC chapters of all time. The MedPAC staff goes out to look at these hospitals that are actually not losing money on Medicare payment, which is about less than 25% of American hospitals. And it tries to understand, well, what's different about these hospitals? And the dominant finding was that what was different about them is they didn't have the market power to leverage the insurance companies. They were relatively weak in their market, and the CEOs are saying, it was either bring my cost of production down below what Medicare pays, or I'm out of business. And it's further illustration that if there was if you could turn up the dial on value competition, not just in the public sector, but this was private sector payments that really was the discovery that Medicare found. And then along the lines of what Kevin and Bill were suggesting, give both incumbents and challengers, a lot more flexibility in their healthcare production methods. I think we might be able to achieve something that's analogous to the fracking metaphor that Bill outlined.
Yeah, and I do want to just bring everyone back to when you go from the iron triangle to the triple aim, it ceases to be about a single moment of national consensus, and it starts to be much more about people in their businesses, with the people they care about, with the regulators they know, trying and doing things differently. It's really a different project. It's not that there isn't a national policy need, there is, but it's not that tragic choices. We all have to decide how much we get of each characteristic. We can do better on all characteristics, and we're going to do it largely in a market-based, decentralized way.
Jim, in the corner there.
Just a sort of broad question around for either of you. The presumption here is that there could be a lot of disruptive innovation from some source, and it would respond to a lot of trapped resources and save everybody a lot of money and provide better health care and so on. I guess I'm still missing from the equation here is who's the driving force, who's going to make money in the process and have an incentive to get in there, and how will they make the money to do it? Who's going to pay them for delivering cheaper, better health care?
All right, so first off, if we took our system, just chuck the entire U.S. healthcare system and adopt the Swiss healthcare system, okay? A really high-performing healthcare system accomplishes all the goals we talked about. That's almost 6 points of GDP, which means you could give free public education to everyone who wanted public university. You could build all the roads and bridges that we could think of, and you could actually eliminate the federal debt before they play games with taxes again. But that's the magnitude of the difference in terms of the trillions of dollars. That's just going from our system and their systems over $1 trillion. So if you said to Apple, Google, Tesla, here's an opportunity to keep 20% of $1 trillion, that's a big number. The flip side is, how hard are the incumbents going to me, I think the issue is who has the monopoly rents in the system and how can you use those monopoly rents to fight off that innovation? And that's what's going on. I mean, I'm sure every time 340B payment policy change, whatever it is, obviously there's 1,000 of us up here explaining why that's not really a good idea. You get an innovator, you get two guys in a garage or a guy and two gals in a garage trying to do the disruptive healthcare thing. 30 seconds later, there'll be a lobbyist closing that off. And so I think that's our big struggle.
Jim, let me answer your question by coming back to the fracking metaphor, which I've actually spent a lot of time thinking and writing about, and we'll do this more over the next year or so. I've talked about the geologists being people who found the existence of the trapped resources and the legal engineers to free it. But if you go back to regular fracking, hydraulic fracturing of rock, the wildcatters got in under the noses of big oil. Okay, big oil was there, the equivalent of the doctors in the hospital. They were there. But the wildcatters found the small opportunities, and they made it happen. And what they often had to do was negotiate with the rights holders, which were the little landowners who had mineral rights below, and no one had ever been able to negotiate with them or bothered because the shale rock under was not yielding gas or oil under established processes. The wildcatters are there. The rights holders are there in healthcare. There are people coming up with all of these innovations, the mHealth, some are big companies, some are little companies. And then you have to say, well, who are the rights holders? And to my mind, the rights holders are actually the empowered professionals right now, none of whom really wants to say, okay, I just run things so I can make a whole bunch of money and keep most of the country from getting healthcare they need. Oh, and by the way, crowding out educational investment and a bunch of other things. Now, if you talk to American physicians, that's not what they want to be doing. And so I think there is a negotiation process where you really kind of take on the ethical underpinnings of what our highly empowered, legally empowered medical profession wants to be doing. You take on the ethical underpinnings and you work to kind of free with them the permission to go ahead and then get the resources out. And I think that's the metaphor I'd urge.
I get it, but I think the subtext of what you're saying is that they would sort of voluntarily give up 25% of their revenue stream because they know that it's wasteful medicine. And count me skeptical.
I share the skepticism, and I'm not really saying that. First of all, I'm just saying if the people who figured out where we need to go and how we should get there can't step back and say we're not already there because all these laws freeze us in place, and this is law writ large at many levels, and a lot of it's professional habit and privilege. You have to get there first. Once you kind of start thinking about those things, and again with the triple aim frame of you're not resetting national policy, you're working in pockets to make incremental improvements, then yeah, I actually think people do give things up. I think that there are things that are not threatening to the big oil equivalents, or not that threatening, or they don't want to have a bad headline, or they don't want to alienate their biggest emitter. But yeah, I actually think there is space there. If there's one thing I think needs improvement, is I don't think we don't have enough real buyers in the healthcare system. We've taken our buyers, we've either sheltered or subsidized them, or recently in sort of the ACO model, we've kind of mushed them together with the sellers and hoped that it'll work out collaboratively. And I do think it would be nice to try to reconstitute some real buyers in the system.
I think one cause for optimism, there's not necessarily a point of resistance. At our place, the overhead costs are 50 to 75% of collections, right? So you don't have to think about units of service. You could think about how do I get more money to take home? And if I reduce the administrative costs, I could share that 50-50 and take home more money. So, if we believe a third of the costs of the U.S. healthcare system are administrative and overhead costs, we don't have to play games with did you order the MRI or not. It's just why can't it cost me 2% to submit a bill instead of 14%? That's money I could take home and share. So, I think there's plenty of opportunities for physicians to get engaged if we could point them away to ways in which it'll benefit them by going to these new models.
So we don't have to get rid of all the waste. We can convert some of it into profit. It's somewhat like biodegradables that can be made into energy, I suppose. Arnie has a follow-up comment.
I think probably today the best candidates for for the wild equivalents of the wildcatters are going to be these primary care doctors that are needing to get some Wall Street money to take global quality-adjusted global capitation, and begin to not initially replace all the health insurance functions, but take global capitation rates, and then eventually perhaps get big enough to start their own health insurance companies, which is essentially was the story 15 years ago of CareMore, for example, in Southern California, and there have been a variety of other illustrations. The Leon Medical Center operation in Miami. I think it's primary care doctors who today are not making all that much money. Those are the people who are the most discontent, and I think because they control so much of healthcare spending, per my opening remarks. I think they're our best shot as being our wildcatters. Whether they can overcome all the sort of structural barriers and fully take advantage of opportunities to sort of downshift tasks to technology and lower paid people, probably not as much as we would like them to be. But nonetheless, those are, I think, our best shot at wildcatters, and in some states, independently practicing nurse practitioners.
What you've heard this morning is that this remains a target-rich environment with a multiplicity of opportunities and tools. You're not going to agree on any one single strategy, but it might be helpful to start drilling. And then please thank our panel for a wonderful presentation.
Great presentation.
Thanks. You too. I mean, the funny thing is, we should talk more because there's obviously